touch on this topic and, prefer recommendations and a way forward for us within the cancer space. So briefly, before we begin, we'd like to do some housekeeping. First, if you are not speaking, kindly mute yourselves. Secondly, if you have questions, comments, suggestions, or whatever it might be, kindly leave your comment in the chat box. At the end of the session, all questions and comments would be attended to. And lastly, in the course of the discussion, if you find anything useful, insightful, and interesting, please, share on social media using the hashtag Foundation for Cancer Care. Okay. So quickly, we'll start with an introduction by Foundation for Cancer Care's Programs Coordinator, Tolu Lokpe, and we will move ahead into the panel discussion, after which we'll take contributions and questions from the audience. So why are we doing this today? So basically the objectives, why did we convene this webinar today? So first of all, we would like to, look into ethical issues around cancer care, from screening to treatment. When you screen people, what next? Do you leave them hanging or do you provide treatment for them? Secondly, we would like to explore support options for cancer patients as a whole. And lastly, we would like to discuss strategies on a way forward for nonprofits within the cancer space. So now I will give the mic over to Tolu Lokpe, who is our programs coordinator, to give a brief introduction. Tolu.
Okay, good afternoon, everyone. Thank you very much, Amanda, for that introduction. And thank you to everyone who is here present at this webinar. We really appreciate your time, and we are certain that it will be worth it. So I will just do a brief introduction about the Foundation for Cancer Care. So we are a non-profit organization, and basically, we do everything from cancer education and awareness, cancer screening, support for indigent patients in terms of treatment. And we also have a support group that we coordinate. So we do, all of this, ensuring that we're able to reach people in indigent communities. Basically, that's our major focus. And so far, since we commenced operations, we've been able to reach over 12,000 people with education and awareness through, webinars such as this. We have a school program, which is called the Crush Cancer Early campaign, where we go to secondary schools and educate, young secondary school students about cancer and, how to reduce their risk as they grow. We've also been able to provide over 1,000 free clinical breast exams and cervical cancer screening for women, over 600 mammogram screenings for women in low resource settings. We've also been able to provide funding support to about 17 patients who needed support, that's radiotherapy specifically. We've been able to reach about 15 communities, and we have about 100 survivors within our cancer support group. So basically, we decided to convene this webinar because as nonprofits, it's important for us to find out, how we can address some of the challenges and some of the barriers that are available, to the work that we do. We are all cancer advocates, we go on field, and definitely there are challenges, there are barriers. So, this is a forum for us to learn from other organizations and advocates who are actively engaged and, doing excellently on how to navigate some of these challenges. So it's really a forum for us to learn. It's a forum for us to, share ideas, and so that at the end of the day, we go back and do better within our organizations. So we have an amazing lineup of speakers who we know will certainly do justice to this topic. And, we're really looking forward to an amazing discussion. So everyone just sit back, relax, and, let's just have a lovely conversation. So thank you very much once again from the Foundation for Cancer Care. And at this point, I'll just hand it over to Amanda.
All right, thank you very much, Tolu, for that wonderful introduction of the foundation. As she has mentioned, we do quite a lot and we're making impacts within Nigeria and the world at large. So briefly, before we introduce our panelists, today we're talking about breaking barriers, and it's important, we touch on some of these barriers that people encounter, especially from health-seeking behaviors to cancer care treatment itself. And when looking at these barriers, accessibility is one major factor, one hindrance to cancer care in Nigeria in particular. And when we talk about accessibility, it's not limited to just physical availability of services, but we also consider, is it acceptable and is it affordable? Because what's the cost like? Can people afford care? Can people afford screening? And are the methods available acceptable to the community? Is there stigma around cancer care in the community? And when we now talk about cost again, just this morning I saw a post about how much drugs cost now due to the economic inflation, and it's alarming. Little drugs like paracetamol, it's so expensive, and when you now talk of cancer medications, it's so expensive. So what do we do? How do we break these barriers, and how can we move forward within the cancer space to provide the care that is needed for patients and the populace at large? So once again, before I introduce our panelists, if you have any comments, questions, leave them in the chat box. And if you find anything interesting from this session, kindly share via your social media using the hashtag Foundation for Cancer Care. So right now I will be introducing the first panelist for the day. Her name is Dr. Nchinwe Annie, and she is a medical doctor and consultant radiologist and the founder of Pink Africa Foundation, and they are into basically breast and cervical cancer. So today she will be talking about recommendations for breaking barriers within the cancer space, from health-seeking behaviors to treatment. So kindly welcome Dr. Nchinwe to the floor. Thank you very much, Dr. Nchinwe.
Hi, everyone. Good afternoon, cancer advocates all over the world. It's nice to be here. Thanks for having me.
We're excited to have you here today. Thank you, Ma.
Yeah.
Okay, so, when we talk about recommendations within the cancer space from health-seeking behaviors, previously I talked about some of these barriers, such as accessibility, the cost, and its acceptance. So, Dr. Achinwe, are there any recommendations you have for non-profits, for cancer care facilities in breaking these barriers within the cancer space, especially health-seeking behaviors such as early screening and detection and seeking for early treatment when needed?
Thank you for the question. I would like to start with identifying the barriers. It's said that if you know where the problem is, your problem is half solved. So I was able to categorize the barriers that we are facing in our country, peculiar to us, under 9 subheadings. First of all, we have barriers with regards to awareness and education. We also have barriers with regards to the prevalent socioeconomic condition, of the African continent, and Nigeria is no exception. We also have barriers with regards to cultural beliefs and stigmas related to cancer-related illnesses. The healthcare system itself poses a formidable barrier, depending on where you live, how much you can afford, and the existing healthcare services available. We also talk about psychosocial or psychological barrier. A cancer patient will need support all the way. So mental health is crucial. I will also talk about a language and communication. If someone who has cancer, whose primary means of communication is not English language, then the person cannot express himself to the healthcare physicians or the healthcare providers, and that will institute some form of barriers too. And then what is actually prevalent on the African continent, in Nigeria especially, is that we don't have adequate access to advanced treatment. We're not connected to existing research or trials where our patients can have access to, state-of-the-art recent treatment services that are available. And then last but not the least, the legislation and the policies regard to the existing healthcare services we have in our country, it's a barrier. So how do we take care of these barriers? With regards to awareness and education, I know that the Nigerian Cancer Society has a myriad of non-profit organizations that have taken the bull by the horn. They have, in the last 5 years, I think I have witnessed an upsurge of awareness with regards to cancer care, cancer education, and cancer advocacy as a whole. Lakeshore is doing a lot. Foundation for Cancer Care is doing Project Pink Blue, to mention the Medicaid Foundation, and then down south, Pink Africa Foundation. I know that the Medical Women is doing a lot. Nigerian Medical Association, a couple of years, have had a cancer advocacy desk, and they are doing a lot on a daily basis. But the problem we will ask ourselves is, the woman on the streets in the marketplace who is not educated and cannot read, woman in the hard-to-reach areas, underserved population, are they able to gain access to the education and the awareness we are trying to do? So there's a lot we need to do. We need to go the extra mile, and take this awareness to underserved population, hard-to-reach regions where transportation is a problem and there's communication problems too. Then we talk about the psychosocial barriers. How do we overcome that? Hello? Are you with me?
Yes, we're together.
I don't know if I'm talking too fast. When you talk about psychosocial barrier, cancer itself, it's a disease that, takes a lot of money. It's no respecter of persons. It does not respect your pocket, does not respect your religious affiliation, your political affiliation. And when it gets to your doorstep, you will need all the financial support you can get. In our country, Nigeria, I don't know if I can place my finger on any stable financial support program for cancer patients. And when you talk about financial support should take care of either in part or whole cost of treatment, cost of transportation from, from rural spaces to urban spaces where most of our healthcare facilities are available. It should take care of cost of lodging. You lodge a patient comes in, drives five hours away to access radiotherapy support, say in Abuja or in Calabar or in Enugu or in Kano, and has to, in addition to paying for radiotherapy, has to cough out 1/3 of the cost of radiotherapy for lodgings and accommodation, and has to take care of the caregiver. So as NGOs and non-profits, we can avail ourselves, of this, help cushion these effects by, providing lodgings, subsidized lodgings for patients who, have traveled a long distance and they need to access healthcare. And then we want to talk about insurance, National Health Insurance Scheme. They've tried in the last 2 years, but you see, catastrophic funding with regards to cancer care is top on the charts in our healthcare system. Somebody has cancer, it means that either money for food or money for education of one member of the family or the entire member of the family, or you have to sell things to be able to support that member of the family. That's usually the problem. So we are saying, can we have more insurance group, invest in providing support for our cancer patients. And then the third one we will talk about is culture and the stigmas related. Somebody has cancer, half of our friends will not want to support. They will not want to associate with the person. Some people believe that cancer is even by association. If you talk to someone who has cancer, which is not true. That means that you also will have cancer. If you identify with someone who has cancer, you also have cancer. So that cultural barrier, does not allow for people to lend a helping hand where necessary. So how do we do this? We have to do something we call cultural competence training, where we as nonprofit or the healthcare system will have some form of support and form a bridge between the community and the patient, or families and the patient, to explain the procedures to the patients and the patient's family, encourage family and friends to support our cancer patients. And then community outreaches go a long way, taking this help and this education to the rural spaces, to the villages, the local government areas, will go a long way to help us bridge the existing gap or take a road the barriers that we face. Now, the healthcare sector in Nigeria itself, it's upcoming. There are lots of things that we do not have. I think we have about 9 to 12 radiotherapy units, functional radio-oncology centers in Nigeria. But cost is also a problem. You need to save at least 600,000 to 1 million or 1.5 billion to be able to assess, a one-time treatment for cancer patients. And we are saying the government can do something about it, either part sponsor for indigent patients or give some kind of step-down payment model that will enable patients to be able to access radiotherapy and increase their chances of survival. Then what else can we do to bridge the existing healthcare needs or gap? The government can also set up mobile clinics. They can set up telemedicine practices, and you can partner with local healthcare professionals. You can partner with the private hospitals in the local government areas, association of private practitioners in Nigeria, partner with them to see how they can help solve this problem of manpower and availability of facilities and resources to treat our cancer patient. And then something that is not so much in existence or entrenched in the healthcare service of Nigeria is the patient navigation system. The patient navigation system, whereby you have people who are trained patient navigators that would help the patients understand their diagnosis, help them follow up with treatment options, help them navigate the healthcare systems, that is existing within their locale. If we, as Nigeria will invest, or the Ministry of Health invest in patient navigation, then I think it will increase, the chances of survival of our patients. I think I will stop there, except that someone else wants to say it, and I can continue thereafter. Or do I continue?
So I think we can give it a pause for now, and we can revisit the topic later. But everything you mentioned are vital components, and honestly, some of these I doubt many of us have thought about it and considered it. You talked about lodging. That is something that is very, very vital, because a lot of people don't have where to stay when they come to receive care. We have certain patients who have needed funding, and they come from different parts of the country to Lagos, and many of the times they don't have where to stay. They are hanging around and looking for what to live on, because all their money is into the care that they are about to receive. So that lodging itself is going to be important. And you also talked about partnership with the private sector. And recently, just reading about healthcare systems all over the world, it's important to know that all other countries, they don't just survive alone. The government doesn't do everything by themselves. They usually partner with the private sector to make this care available to other people and accessible and affordable as well. So all this, your recommendations, honestly, I believe they would go a long way if we choose to come together and, implement all of this. Thank you very much, Dr. Nchinwe, for that.
Thank you. Appreciate it.
Okay. So, as I mentioned earlier, if you have comments, questions, or suggestions, just kindly leave it in the chat box. We will attend to them as soon as we come to the end of the panel sessions. Also, please feel free to use the reaction buttons to, applaud the speakers or give a thumbs up to the speakers if you feel like what they're saying makes a lot of sense. Okay, so we would go next to our next speaker, who is Gloria Oku. She is the programs coordinator of Project Pink Blue, and she's a trained linguistic. And she's also a survivor of breast cancer. She's a member of the Abuja Breast Cancer Support Group and vice president of the Network of People Affected by Cancer in Nigeria. Gloria has so much experience as a professional working within the cancer space, and as well as a survivor and advocate for cancer. And briefly, in 10 minutes, she will be touching on ethical considerations in cancer care, from screening to treatment, informed consent. When we screen, what's next? Tolu, in her introduction, talked about that. When we screen, do we leave them alone? Do we provide help for them? Do we provide support? What do we do? So Gloria is briefly going to touch on this point. So Gloria, thank you for joining us today. So you have the floor now.
Hello, thank you so much for having me. I think I'm going to turn off my camera so that my network will be very stable. I have an unstable network. I hope you don't mind. Okay, thank you. Fine. Yes, so thank you for this interesting topic. And I presume we've been offered this topic because at Project Pink Blue, we do a lot of screening for cancer patients, either as Project Pink Blue or in collaboration with partners who are interested. And over the years, we've done tons and tons of screening for cervical cancer, breast cancer, prostate cancer, and even HPV, even hepatitis, I mean to say. And other screenings, the big screenings that would also do at our World Cancer Day. Yeah, and yes, we understand that there has to be ethics around these screenings. And from what I'm supposed to talk about, I'm supposed to talk about informed consent. After screening, what happens? What are the ethics, patient education, and potential psychological impact? First of all, I think a cancer screening must be effective as well as cost-effective to be ethical. We need to look at how we can make, in Nigeria, so many NGOs do a lot of screening, and I think it's high time we stop working in silos and start working together to make sure that what we are doing is not just efficient, but effective in the long run. And that is only what will help us make impact and make a difference. The effects of these screenings needs to be evaluated. And we should have a program for monitoring the quality of screenings that are carried out. At the Project Pink Blue, yes, we have a program for monitoring the quality of screenings because we work with health professionals directly. Most of us are Project Pink Blue. For instance, I'm a linguist. Mr. Ross is a psychologist. All of us have different professions. None of us is a medical personnel. So we always engage medical personnel to give us expert advice. Are there changes? Are there things we need to do better when it comes to screening, since we do not have this experience? And that helps us to monitor the quality of our screenings per time. And then there have to be an invitation and a reminder system for your participants as well. Because if you want to make the most impact, you have to bring people. So if you want to do a screening exercise and you don't, would have wasted money to get, and nobody comes, and it doesn't make sense. So there has to be a system of invitation and a reminder system to make sure you bring your target group, your beneficiaries, for that screening. This will increase the uptake of the program and the impact you will make in the long run. And then when you finish the screening, these are pre-screening activities, that are related to ethics. When you finish the screening, what happens? The next thing is that there has to be limited time interval between screening and examination and the information of results. You see, many times we've done screening, in the next 2-3 days, some people are losing it. They're so afraid. They want to know if that thing they felt in their breast is a lump. They want to know if, oh, there was how this nurse was looking at me while checking my cervix. Maybe I have cervical cancer. They are scared. They need to know as quickly as possible what their results are so they can move on with their lives. The more you delay, the more you cause them anxiety, the more you cause them panic, the more you cause them headaches that might end up being unnecessary at the end of the day. So we try as much as we can to reduce the necessary stress on participants by having short time between examinations and release of results. And screening should be highly sensitive and specific for disease. So in this area, for men, prostate cancer, that's what we do for men. PSA is what we do for men most of the time. And because they are men and we just need blood, it's something we can just keep a sit and table and we do outside and we get our information. For women, we have to build tents because they're going to take off their clothes. They need more privacy. Or take off their shirts for you to check the breast. And so we're going to build tents. We're going to provide fans inside the tent to make them as comfortable as possible. Because this is sensitive, it's sensitive parts of the body that has been exposed. So we also have to be sensitive in our response in these screenings. That also makes your screening ethical. And then recall, in case you have to recall some results, you should have minimal. For instance, you send out a result and the person says, no, this cannot be my result. And you have to recall that result to check. You should have very minimal cases of recalling results after your screenings. And if you have to do that, it should be very, very early. Everything should be happening very, very quickly. So if you recall a lot of results, it makes your screening lose quality. People are going to start asking, oh, am I even sure my own is correct? Am I even sure they did the right thing? So if you ever have to recall results, they have to be very, very low number. And these screenings, are ethical when the effect of the screening has been validated in scientific studies. So the importance of this screening should have been validated. The impact of the screening should have been validated by some scientific studies to show that you know what you're doing and for people to measure impact even before they come in for your screening. But if your screening has no scientific backing, no scientific impact already postulated, it just renders the quality of, it just waters down the quality of whatever screening you're doing because what science backs it? What shows that what you're doing is the right thing? So then you need a psychologist before people go in for screening. And you might also need a psychologist when people come out for screening. So a psychologist is going to talk to people when they go in because there's always this panic, there's always this fear. In Nigeria, people don't usually go to the clinic except they are sick. That's when they have need to. Sometimes they don't want to, but they'll tell you, oh, what you don't know will not kill you. So there's an inherent scare and fear. And some people will ask you, so what if I go in and do the screening and I have cancer? I don't have money to treat myself. Why should I know? So you need a psychologist to address some of these fears before people go in. And in our screenings, we make sure we have a team, not just one, we have a team of psychologists for each screening we do. Trained psychologists who talk to people, who calm them down and educate them on the need for this screening. And the likely consequences, and of course, assure them that they will be held, their hand will be held all through the process, just to make them relaxed, during the screening process. So you really, really need psychologists. And sometimes you have to also work with professionals. That's why we say work with health professionals. But at the same time, we also talk to them how we want the results to be disseminated. Now, some health professionals, you go ahead to tell somebody inside the screening room, oh, your service is not looking good, though. I'm not sure you are okay. You've messed up the person's entire day. You've messed up the person's entire week. Till the person gets the result, the person is panicking and scared. So we also educate our healthcare workers from a psychological point that please, it is not in your place to give out results or to give out information on screenings. We always do that. You understand? It is not our place. And before we give out these results as well, if somebody has a good result, or no lumps, nothing, everything is fine, we can send us SMS, we can give physically, depending, telling people to come to our office might be stressful. So since you don't have any issues, you can just send an SMS, sharing your result with you, tell you congratulations, you're fine, please continue doing this so you don't miss any opportunity of early detection. But for those who have results with abnormalities, we become more careful. We have to invite them to the office for a face-to-face talk. We have to have a psychologist on the team and our team members who have been trained over time to deliver these services. And then we speak to this person, oh, we found some abnormalities, but hey, don't worry. Nobody's saying it's cancer yet. This is just the first stage. We are going to proceed to the next stage to be sure you're fine. And at this next stage, of course, we always pay. We pay until we get the last diagnosis. And so we lead people on this journey. And then we'll tell you, oh, we're going to pay for the next, do a mammogram, we're going to pay. Please go ahead and do a pap smear, we're going to pay. We pay all of this, we follow you through, we get your results, you come to the office, we give you the results. And some people will say, oh, I already have my doctor, let me go meet my doctor. And they go and meet their doctor, and we still follow them up to know what their doctor says. Like in our last screening, we had almost 8 women that has some one abnormality or the other on their breast. And some of them, about 5 of them already said, oh, yeah, my doctor is aware of this case. I have water discharge. It's a high level of, oh my God, what's this word? Sorry, I forget things. So it's a hormonal issue and I'm being treated. So I'm aware I have this issue. And then we make sure we still follow them up. Please go back to your doctor again with this new result. Let's see if there's anything we need to follow you. And that is how long we follow people up. It keeps them stable. It makes them encouraged. It removes the fear of what happens at the end of this thing. And so far, we've been able to record a lot of success in our screenings. And I want to say that a proper consideration of the potential benefits and harm arising from screenings must be thoroughly considered. For every screening, there's a potential harm, there's a potential benefit. We have to weigh both of them. And most times, of course, as long as it is scientifically validated, the benefits will always outweigh any harm that might come out as a result. And most of this harm, anxiety, fear, or results being misinterpreted or results needed to be called back, whatever harm it is, can be managed, can be mitigated with good counseling, good communication, and enrolling the right people to help you in your screening. People always say all the time, oh, mammogram, they say radiation causes cancer. Why should I do a mammogram all the time and all that? But I always tell them, when you check the consequences of not ever doing a mammogram, and you check the benefits of doing a mammogram, the benefits always outweighs the harm, of whatever cause of radiation you are scared of. So let's go for this other option. And that's what happens for all the treatments. Every drug you take has a side effect. But we take them nonetheless. Why? The benefits of taking the drug outweighs the side effects you're likely going to feel from that drug. I think the side effects is going to outweigh the benefits. Of course, doctor will tell that there should be a scientific backing to that. So these are some of the principles we observe in our screenings to make sure that the quality is high, to make sure that people have that confidence in us, to make sure that we make impact, long-lasting and proven impact to the communities. And then I want to say a very big thank you. I think I should stop here now. We are still going to have screenings for our World Cancer Day in February. So anybody here who is interested, you can come for these screenings I mentioned on our World Cancer Day, first Saturday of February, and you'll get these screenings free of charge. And for the other ones we do all through the year, we keep communicating to all of you. So thank you. I think I need to stop now.
All right. Thank you
Thank you,
very much,
Amanda.
Gloria.
Welcome.
Thank you very much. That was very insightful. You touched up on from psychological support to counseling from also the psychological perspective to, incorporating other sectors of health, relating to health. You talked about the language barrier. Then you talked about recalls in your results, and you also talked about follow-up, which are all essential parts of like the ethical things to consider in the screening process and cancer care as a whole. Thank you so much for that. And thank you everyone for the comments you are leaving in the comment section. Kindly note that they would all be addressed at the end of the panel discussion. Once again, if you find anything insightful or interesting, please make sure to, share via your social media platforms using Foundation for Cancer Care as the hashtag. Okay, moving on quickly to our next speakers, who will be talking about support for diagnosed cancer patients. We have Dr. Emmanuel Andero, who is a consultant clinical and radiation oncologist at NSI Luth. And we have our very own Dr. Chine Iwuji, who is the medical consultant oncologist, the head medical consultant oncologist at Lakeshore Cancer Center. So briefly, they will be touching on areas around support for cancer patients who were, diagnosed. So we will start with Dr. Emmanuel. Dr. Emmanuel, are you here with us?
Yes, good afternoon, everyone.
Okay, hello, good afternoon, Dr. Emmanuel. It's nice to have you with us today. So, briefly, we'd like to touch on issues around support for diagnosed patients, and from permit me to use the word, from the public sector perspective, what are there any support systems available for cancer patients who have been diagnosed?
Yeah, thanks once again for this very important forum. Yes, talking about support for diagnosed cancer patients, this is very important. It is as important as giving, the definitive treatment to the patient. It's been known from research that patients that do have robust emotional support, psychological support, they do better. They fare better in the course of their treatment and all the way. I will be quick to mention as well that support for cancer patients spans all the way from diagnosis through treatment to follow-up and end-of-life care or hospices. Now, talking about, right from diagnosis, this is so very important. And before I talk about the supports that are available, it is at the point of diagnosis that it's either we get it right or we get it wrong. And sometimes that will also define how the patient will, how the patient will fare all the way. We know at the point of diagnosis, patients are known to display quite a number of emotions ranging from fear, anger, resentment to guilt, to loneliness, to frustration, to the feeling of, blame and all whatnot. Now, it is if we know and we have a better understanding of this emotional display, it helps us to be able to know how to manage this patient. Now, and that is why patients walking through your consulting room or at the point of consultation. So there are times when, if you do not have this understanding, we are quick to judge the patient. Right. It's still at the stage where they are trying to come to terms with the diagnosis. And unfortunately, in this part of the world, probably somewhere in the West. I wouldn't be able to say for sure. But I think it's very, very common among us here in this part of the world where oftentimes we focus more on treating the patient than treating the old patient, right? What I mean in essence is, so they walk through your. I'm going to be more practical in this conversation. A patient walks through your consulting room, and then we're quick to pick a pen, scribbling investigations, scribbling tests, and this and that. Meanwhile, the patient, right, has come with loads of concerns and questions, and is looking into your face and wants this answer. And the next thing is you are asking your medical officer or anybody, waiting on you, please write this form, fill that form, that imaging, and then please go and come back. Okay, the patient leaves the office, and then the patient is back with the test, and the next thing is I pick my pen, I'm prescribing chemotherapy, I'm prescribing radiation therapy, or whatever kind of therapy I'm giving to the patient. The patient leaves with more questions than answers, right? So, but at the point of entry, the starting point, it's at the point where we should try as much as possible to kind of establish, that connect with the patient. And in my own practice, I'm very being intentional. They come to my office, the first thing I let them know is that cancer is not a death sentence, and offering those few words of reassurance, you can notice in their faces, they now want to relax, they want to listen to you. Mentioning in part the support, of course, where I practice at NSI Cancer Center, we have a very robust support for our patients. We have trained oncologists, and with scheduled appointments for, for support and, talking about the psychology need or psychological support for the patient, right? However, even as an oncologist too, and physicians and caregivers, every point at every stage where the patient has the opportunity of being in touch with us, and unfortunately for some, we are going to be the last bus stop before they breathe their last. We should try as much as possible to make it count. And like I was saying, it should begin from having the understanding of, okay, some emotional display we see among these patients, it is just the natural reaction. And this is where medical psychology, learning in medical school, comes to the front, to the fore. I mean, if there's any practice.
Hello, Dr. Emmanuel. Seems like we lost you. Okay, just to clarify, I would like to know if the network if it's unclear on everybody else's part.
Yes, he's frozen on my side as well.
All right. So okay. Pending when we
It's
can
clear, it's clear over here.
Okay, seems like there's a conflict going on. Okay, so pending when we can have him back, our next speaker, Dr. Chineye Iwuji, will continue from where he stopped. And okay, good afternoon, Dr. Chineye. Nice to have you on the call.
Good afternoon.
Yes. So quickly, regarding patient navigation and referral, Dr. Nchinwe, gave that as a recommendation for breaking this barrier in cancer care. So how would you advise that we go about patient navigation and referral, as a cancer facility and as NGOs as well? And also regarding collaboration with non-governmental organizations, what do you encourage that we do in the cancer space?
Okay, thank you. Thank you for having me to speak this afternoon, and thank you for that question. So I think it's important for us to recognize that for our patients, this cancer journey, it's a long and it's a very tedious journey. And it starts right from day one when they're trying to get their initial diagnosis. So it is known that most cancer patients see up to 4 different consultants before they even get their diagnosis in the first place. And this is obviously at significant cost to them. As well as that, there are issues with how long it's for the patient to present in the first place. It can take up to 8 to 15 months for a patient to present at a hospital to see a doctor from the time that they actually first notice any symptoms. And then on top of that, as they're going, so they've already taken 8 to 15 months to present to a doctor. Then they go to different doctors for first, second, third, fourth opinions. And then after all of that, it takes quite a long time for their investigators to come back. So if we see a patient and, for example, we say they need a biopsy, it can take anything from 2 days to 3 months for biopsies to come back. And actually, it's more common for it to be in the realms of 2 to 3 months for some of these biopsy results to come back. And all this time, the patient is waiting before they can even start the treatment that they need for their cancer. And this is before we even go to the issue of how much it is costing them to have all these different investigations and see all these different specialists. So our role as healthcare professionals would be to try as much as possible to streamline the referral process, to streamline the investigation process for these patients when they come to us specifically. Now, there are a number of different ways of doing that. At Lakeshore Cancer Center, what we have is our multidisciplinary team meeting. So that's where patients who have come to see us at Lakeshore, who we believe have a diagnosis of cancer, are discussed in a meeting with different healthcare professionals. So the oncologist would be there, the radiology consultant that's reviewing their scans would be there, the surgeons would be there, and any other relevant, and the pathologist as well, who would be interpreting the results of their biopsy. So that's quite a good forum, because what happens is that when a patient has their case discussed in the multidisciplinary team meeting, if I then need them to be reviewed by one of my colleagues, if I need them to see a surgeon, then often that surgeon would have been in that multidisciplinary team meeting in the first place, and therefore they already know the patient's case, and it's a smoother referral process. If I need their scans to be reviewed or their pathology to be reviewed to get a clearer idea of their overall diagnosis, then again, that has already been done in our forum, so that those people who are interpreting their scans and pathology already know their case and have a better understanding of the patient. So that can also really, really help with streamlining the referral process. I think as well as that, it's important for us to communicate with the patient, like a lot of my other speakers, the speakers before me have said, to explain to them the pathway so that they know what we're doing and why we're doing it, and also to manage their expectations. So obviously, for anyone who is told that they have cancer, they want immediate treatment as soon as possible. A lot of the time, they might want something like immediate surgery to get the cancer out, but that might not be the best treatment plan for them at that in time. So it's important that we also counsel the patients and explain to them that, look, this is what we think you have. And in order for us to give you the best treatment possible, this is the way you need to go through. You need to first get your scans done so that we can see how advanced the cancer is. We need to second make sure that we've got the biopsy done and the results of that biopsy so that we know what kind of cancer we're dealing with. And even after that biopsy, often we might need to get further tests like immunohistochemistry, which is another form of a more specialized form of histology done, so that we know exactly how to target the treatment for you specifically. And when we have these results back, you might not go straight to surgery. You might need chemotherapy first, or even after you have surgery, you might need radiotherapy thereafter. And so it's important for us to explain all of these things to the patient and also explain to them the timeline and say, it might take 2, 4 weeks, 6 weeks for your pathology to come back, so that they don't think that we're delaying their care. They understand that this is the referral process and this is the time it takes, and then we can manage their expectations and thereby reduce their anxiety as they're going through this treatment. But similarly, from our point of view, as we are making these referrals to our colleagues, much as we may have discussed the patient's case in the multidisciplinary team meeting, we as the referring consultants also need to chase these results up. And so it's great for us at Lakeshore that we have good relationships with our colleagues in different centers. So for example, if I do refer a patient for radiotherapy at NLCC or NSIA Cancer Center, then I'm able to pick up the phone and speak to Dr. Ambero to say, you know, this is a patient that I'm hoping is coming to see you next week for treatment of his prostate cancer. And we can have that discussion. And while we're waiting for some of these results to come through, possibly Dr. Andero can see the patient to say, look, you know, we're going to start planning your radiotherapy. So I think it's about all of us as healthcare professionals having good communication, both with the patients to, you know, to tell them the pathway they're going through and manage their expectations, but also amongst ourselves as healthcare professionals. So that we all are on the same page with the management plan we have for the patient, and also so that we ensure that we're giving the patient the best evidence-based medicine and that we're coming to a consensus as to what is appropriate for this patient. And as we do those referrals across, as I refer a patient to for radiotherapy at Luth or for surgery at another center, we also need to have a clear understanding of when that patient is coming back, because obviously the patients are building a rapport with their doctors. So, you know, my patients might know me because they've been seeing me for a period of time. What they want to make sure is that I'm not just going to send them off to a different hospital to see a doctor that they don't know and abandon them. So we again have to make sure that we make it clear to that patient that when you finish this particular treatment, you are still going to come back to me. As you're having your treatment, I will still be checking up on you every 1 to 2 weeks to see that the treatment is going ahead, and that you're tolerating the side effects of that treatment okay. And then, you know, say to them, when you finish, you will come back to me. But again, what we try and do is have things like patient liaisons and clinical assistants who will keep in touch with the hospitals that we've referred our patients to, so that we know when they're due to finish their treatment. And so I know that I can schedule my patient to see me back in my clinic in 6 weeks' time or 4 weeks' time after they finished a particular treatment or recovered from their surgery. And so we can then have, again, timelines that we give to the patient, not only to say you'll be seen by this consultant in another hospital on such and such a date, but to also say to them that I will keep tabs on you every 2 weeks, 4 weeks while you're having that treatment. And then in 6 weeks' time, I expect you to come back and continue your care under our team here at Lakeshore. And likewise, it's important for us to do that so that we make sure that in case there's been a glitch in the system, we catch those and our patients are not left waiting. It's interesting how often, you know, you'll say to a patient, I'm referring you to such a place, and if they don't hear back from either ourselves or the referring center, they're not often proactive about reaching out. So I think it's important to also that we empower our patients or let us know if they haven't heard back from the people that we've referred them to. So those are some of the main things that I would say help with the patient navigation and referral system. I think that's all I want to say about that. So thank you very much. And as you said, I'm open to questions in the chat.
All right, thank you very much, Dr. Chineye, for that insightful one. And I like the way this webinar has been focusing on communication, because something that is, you know, not emphasized enough within the healthcare system is communication. And, you know, communication is not restricted to just speaking and responding, but the flow of communication itself, the understanding that comes with communication. We talked about following up, letting your patients know we haven't left you, even if I'm referring you to another hospital, to another clinic, we are still in touch with you. All of this is, you know, they are important elements in providing care and breaking these barriers in cancer care and support. So we will, you know, we're running out of time now. So quickly, we will go on to our next speaker, who is Mr. Ugochukwu Nwosu. He is the programs coordinator at ACT Foundation, Aspire Coronation Trust Foundation. And, you know, he does a lot of work around expanding partnerships and sustainability systems to fortify the nonprofit sector within Nigeria and, you know, the region at large. So briefly, Mr. Nwosu will be talking about, you know, ways forward. What can we do? Is there a roadmap, you know, we can follow to, you know, create a sustainable base for the nonprofit sector in Nigeria? So briefly, he will be touching on, you know, exploring methods from financial support to advocacy to collaboration at large, and all other ways we can, you know, work together and reduce the cancer burden at large. So, Mr. Ugochukwu, are you on the call with us?
Yeah, hi, good afternoon.
Hello, good afternoon.
I hope you guys can hear me.
Yes, I can hear you.
All right, thank you very much, Amanda. Okay, I think cancer care, like every other health challenge across Nigeria, it's definitely has a lot of funding gap. I think that from what I saw in the 2023 budget or so was about 5 point something percent. I mean, more like addition of like 1 point something percent from the previous years. At ACT Foundation, first of all, so we're a grant-making organization. We're supporting regional and national organizations across Africa to help them go from the point of funding their projects to also helping them build the capacity, right? I think that so far in the last 6 to 7 years, we have supported about 9 cancer-focused organizations and spent giving them about 100 million. So healthcare keeps being like the top of our grants making every other year. Last year, it was topping the chart of all the grants we made, and it could look same way as well. So at ACT, we intentionally are focusing on non-communicable diseases because most of these diseases are things that has a value chain of prevention, right, of management. So there are things that could be prevented from lifestyle and how we live. There are things that could be prevented from communication and advocacy. There are things that could also be managed by treating them, right? So we have a whole spectrum of opportunity to make sure that people are not dying from these diseases. Now, a very important thing I know, I think that everybody who has spoken here, I was hoping that you would, someone would have mentioned that the Cancer Health Fund, which is quite an interesting innovative way of trying to deal with this situation, right? Cancer treatment has always been very expensive. And here we have we're not as advanced or with enough things to take care of people. But that partnership, I think, was set up in our 2020, where you had the tech company like GE come on, you have the National Health Insurance Scheme, you have the logistics companies like Tanit and JNT. You also have IFC funding. So the idea then was to see that for cancer victims that they spend approximately 20% of the cost of their care. As at this morning when I checked, I was told that it was still there, but I mean, I think that some other people on the call who would know more, like Chinwe and the other ones, they would probably know if this funds access. Man, if they are there, the first question is, do people know that these things are there? People know that how is it being accessed, right? Most times, like a lot of things that happen in Nigeria, it's hard for people to access this process. We even have to make you pay money to get access to some of those funds. So if these things exist, what can we do? On our part, majorly, we know that a lot of organizations have been putting in so much in terms of trying to manage cancer, not just in Nigeria, but also across Africa. And one of the things you can do for the person who's taking care of the child is to make sure that the person is okay, right? So apart from maybe funding certain projects, we have also painstakingly worked to improve the capacity of these organizations to be able to access the funds they need to work. Yeah, because there's a whole lot of people who are interested in doing this work. There are also great team of organizations here and there who are working on cancer, but they don't have the internal structure, to be able to present themselves in a way that they can attract the kind of funding that they need. So that is part of the first thing that we're doing, and which is very critical, because if we have about 10 or so strong organizations who can globally go and talk about how they are dealing with cancer in Nigeria, they could actually attract such funding. Now, the other thing that we are also very keen on is how we can activate local philanthropy. The first speaker was talking about how someone will have cancer or have an issue, but will not have people close to them to help them or assist them. When you look at our economy today, for instance, you can see that regardless of how good many people are, a lot of people are struggling, right? So somebody who's struggling finds it hard to also help somebody else. But we are also working with other philanthropy organizations and also trying to encourage the private sector, because if you don't educate these guys, many people do not know how to practice philanthropy over here. Okay, if we're able to push that and encourage people, educate them on how to, when to, and where to channel the money they want to give out, or even make it intentional for them to give out. I mean, they're very interesting projects that are going on. For instance, in this same Nigeria, there's a project where a telco has set up an organization as a vendor, and every money that vendor is making is being used to fund what that organization was. So we look at some of these innovative ways. It minimizes how much we have to look outside for funding. It also minimizes wastage, because when you know the source of the flow of your funding as an organization, and that you're going to be asked to keep an account of it, then it would no longer be a project use and keep as usual. It would then be more like you now run more like an enterprise, where you know that this is my cost price and this is my output. So I think also the last one would be a lot more collaboration among the sector, more like creating a strong cancer care ecosystem, right? From the guys that make the drugs, just like what the Cancer Health Fund did, from the people that make the drugs to the people who own facilities. Lady from Project Pink, I think, talked about accommodating people. So what happens if, when you're building a cancer care center, another person who's in the hospitality business probably comes in to invest and build accommodation there, and so have some kind of ecosystem that allows people access all these things, from drugs to care and all of them, have them at be able to have them at a cost that can be manageable, right? I know that I've had a relative who was admitted for a long time somewhere in Lagos here, and you had people who were around the hospital whose job was to take care and clean up people who are there who don't have relatives, so they get paid to do that every day. Are we building an ecosystem of such people who are well trained to be able to do all of that? So I think I would stop here. Then maybe we can take questions and discuss for that. Thank you guys very much for the opportunity.
All right, thank you very much, Saf, for that insightful one. You touched on a lot, and what struck me the most was when you talked about local philanthropists, teaching them to channel their money into important causes. I believe that is an important thing we need to do, and I believe ways we can do that is by creating more awareness, making people know the essence and the growing burden of cancer in our country. Thank you very much, sir, once again for that. So briefly, I believe Dr. Emmanuel is back on the call. He was cut off while he was speaking because of the network. You know, the network is also another barrier to cancer care, because imagine trying to be innovative to include telemedicine and our network interrupts us. So Dr. Emmanuel, are you back?
Yes, thank you very much. Yeah, I did have some issues with the network, so I thought it was from my end. Yes. Anyway, briefly, I know I don't have all the time anymore. And then Dr. Iwuji and the previous speakers did touch on some of the issues. But just for emphasis, of course, I did give the highlight of the support needed for diagnosed cancer patients, ranging or spanning through, the point of diagnosis, through their treatment to follow up, and even to the very end, end of life care, I mean, as we call it. So without going back, I mean, not necessarily going back to the point of diagnosis, I mean, because of time. So I was going to talk about the support necessary for the patients at the point of treatment. Now, this is a phase where you have to design your treatment protocol. And of course, at this point too, sometimes we do not give enough information to the patients. And this stage is so very crucial because it is not at a point where, the support needed, I mean, is of less importance. These are the points where you need to explain to the patient some details about the treatment modalities as indicated per case. Quite a number of patients would have come with some distorted information about chemo, for instance. They are going to let you know they heard about Mr. A or B who died of cancer after being given chemotherapy. They are also going to let you know about some people, they were told were taking chemotherapy, they lost their hair, the skin changed, and all kind of reasons why they thought chemo was just a no-no. At this point, we have to find a way to give that support they need, because not giving chemo, of course, is just like telling them, well, let's just keep watching and see what is going to happen without treatment. And it is just but inevitable. In order to make a difference, we have to give them that chemotherapy. So there is a need for that support at this point of treatment to disabuse the mind. And we're in the internet age, right in the palm of their hands, they have their phones for those who are internet savvy. And they've read quite a number of things about chemo, about their cancers and everything. However, it's very unfortunate that many of them are not guided. So they read all this information upside down, and then it's not uncommon in your practice for a patient to come in and say, okay, doctor, I read this about my case, and I think I have just about 6 months to live. I've seen that quite a number of times. Right. So at this point, it is not just enough to just pick your pain and prescribe your chemo or your treatment. So we need to, and that is where we miss it. We need to establish connection with the patient and try to explain to them and their caregivers and relatives, what the treatment is all about, giving them that reassurance, try to let them know you could have heard about this story or about that story, but cases are actually different. And like I was saying, of course, it is of utmost importance that oncology centers across the country if, should employ the services of medical psychologists as well, because these also provide adjunct support. The oncologists sometimes are preoccupied with the major treatment modalities. Like at our center, NSI Lute Cancer Center, of course, we have an in-house oncologist, like I said earlier. And then one key important that I've not really, probably I missed that part, is the nutrition, because this is also key, nutritional support. A patient will let you know that, okay, I read or I was told that I haven't been diagnosed with cancer, I should be eating only unripe plantain and beans. And then that is the only thing they are eating, and then they are losing weight, their heads are failing. And oftentimes people will attribute that to the ongoing treatment. And these are the points where we also need to give them some support, in addition to, when necessary, refer them to a nutritionist who will guide them and give them the necessary support to let them know that, okay, having cancer does not mean you have to necessarily put an additional restriction on yourself. We need to let them know that good nutrition is key to help boost their natural immune system, that can also help in a little way to help to fight cancer. Is so very important. So, and all this.
Okay, so
During treatment, yeah. So briefly, once again, so during treatment, we need to educate them. Okay, what is chemotherapy? This is what chemotherapy is all about. I manage with radiation, and I also need to explain to them what radiation is all about. Of course, referral from here and there. And like Dr. Ewuji rightly said, it's not just enough to refer patients. We should try to follow up with our patient and say, okay, the treatment for which you were referred, okay, how is it going? Because it has to be like a teamwork. Yes, that is very key. And yeah, so much about during treatment. And because of time, what about after treatment?
okay, so okay.
What support
I think the network
when
is
some patients?
okay.
Yeah, sorry, some calls are trying to come in. So we should let the patients know from the word go that your treatment does not end at the point of finishing any prescribed treatment, be it chemotherapy, immunotherapy, radiotherapy, or whatever. Follow-up is key, is an integral part of your management. Now, it is not uncommon for people to rush to the church and give testimony, or their religious center, I'm healed, I'm cured. It's okay. I mean, we're not judging them, but we should let them know that, fine, as much as we would like to give those testimonies, always come back to the hospital for follow-up, because it is not uncommon to see some patients, they come back after 1 or 2 years with recurrent cases. I mean, those that were managed at earlier cases, much earlier diseases, now they are presenting as stage 4. And this is because they are lost to follow up. And at the point of follow up, these are the points where you have to tell them to run certain investigations, imaging, tumor markers that will give you red flags to let them know that, hey, I think where something is cooking. And then we need to, as a matter of urgency, commence some treatment in order to offer a pushback. It is difficult to say, but we should always let them know the truth that managing cancer, the goal at some point is not.
Okay, so it seems
Not
the
to cure,
network
it's to manage
is going off and
the
on.
lifetime.
So
And
we would
yes,
think we
yeah,
would cut it for now. And
exactly.
you know,
So yeah, so
okay.
thank you very much. Yeah, so but finally, if the time will allow me, of course we do have patients at stage 4. Yeah, and these are cases, of course, it's predictable. You can tell how many more weeks or months they have to live. And at this point, they do not need any, we don't have to say, okay, well, after all, they are going to die. After all, you have just 1 week or 2 weeks. Like we do here sometimes, being neglected because we feel, okay, after all, they are going to die anyways. So, but even at this point, we also need to give them that emotional support. And equally to the patient, because when you treat the patient, the family too, they are also affected in one way or the other, financially, emotionally, and we need to, render all the support that it is within our purview and bring in, including the other specialties that, of course, might be able to offer all the necessary support.
All
So at this
right.
point, because of time, I think I have to stop. Thank you
All
very
right,
much.
thank you very much. Thank you very much, Dr. Emmanuel. Like this topic is not exhaustible because there's a lot to talk about. There's a lot
Absolutely.
to impute, especially when you're passionate about it. So thank you very much, sir, for that insightful one. So
My
quickly,
pleasure.
I know we have taken so much time already. So now we will open the floor to comments, questions, and contributions as a whole. So please, if you have a question or a comment, kindly signify and take the floor.
Please, I have a question and comments.
Okay,
My
please
name
go on.
My name is Pastor Mrs. Simabong Andresin, the founder of Only Belief Care Foundation here in Akwa Ibom State.
Thank
I
you,
hope I'm audible enough. All right. I want to say a very big thank you for this session of this Zoom that you have made. It's very helpful. I've really heard so many things and I've learned, even though I joined late. But my focus of concern that I want to bring up to us, especially the medical doctors that are the key speakers of this Zoom session. My concern is there any way the medical doctors can come up, especially those oncologists who are specialists in the cancer care? Is there any way they can stop other doctors from interfering in cancer care treatment? Because you see a general practitioner, you see a dentist, you see all kinds of branches of doctors coming into cancer treatment. Is there any way they can really come up to be of help to the patients? Because most of these doctors do mislead patients a lot. That's number one. Number two, the ACT Foundation do talk about internal structure of some of the NGOs that are standing one leg. In what way can they help? Do I need to private chat them, or because there are some NGOs that may likely need their assistance? Thank you very much.
All right, thank you very much, Ma, for the question. So in order for us to save time, we will, run through questions. Is there any other question? Do we have any other question or comment before Dr. Chine can touch on Mrs. Imabong's question? All right, Runis, please, you can go ahead to ask a question.
Okay, this is Ronsi, not Runis.
Oh, Ronsi, apologies. Thank you.
Yes. Okay, yeah, so thank you very much for hosting this very important session. I've learned a lot, and also thanks for all the speakers. I just wanted to really talk a little bit about the Cancer Health Fund that Mr. Gochuku brought up. I just wanted to say that Cancer Health Fund is such a beautiful initiative. I myself, we played a very important role in ensuring that the federal government actually started the Cancer Health Fund as far as 2019, before it was eventually implemented in 2022. However, I just wanted to say that the major problem with the Cancer Health Fund right now is that the Cancer Health Fund, it's really been domiciled in the Federal Ministry of Health. And right now there is a plan to move the Cancer Health Fund to NICRAT, which is National Institute for Cancer Research and Treatment. However, I think, and we all as Nigerians, and more importantly as advocates, need to ask the big question about what is the most important need for Cancer Health Fund. if you ask me as an advocate, I would say the most important approach for Cancer Health Fund as it is right now is not working, because they have a steering committee of Cancer Health Fund that don't even have any cancer patient in that committee. So you have people caring for providing funding for patients, and then the patient themselves are not there. So the structure need to really be addressed. That's number one. Number two, we have to really start thinking more about system. It's good that the Federal Ministry of Health is managing this fund, but it's better if this fund is actually moved to National Health Insurance Authority, because Ministry of Health is a policy and executive body focused more on implementing policies. They can spend money. However, National Health Insurance Scheme can help provide a better financial structure, and we can really enroll more people. By that way, the country can boast of more people being in insurance. By that way, more cancer patients can enroll in the National Health Insurance Scheme. So these are few. I know this kind of conversation might be something that we need hours and hours to really dive into and argue and discuss, but just wanted to bring these tips of what exactly is happening, and so that we all will be educated and know how or where we think or our own opinion or where we should target to ensure that people impacted by cancer are able to have access to the funding that they need. Thank you.
All right. Thank you very much for that. A very, very valid point. And as you mentioned, this platform wouldn't be enough for us to, air our views about the issue around funding for cancer care and, treatment in general. So thank you very much for your comment. So Dr. Chine, I don't know if you're still on the call, if you can quickly comment on Mrs. Imabong's question relating to general practitioners interfering in cancer care. And Mr. Ugochukwu, you also have a question regarding to how NGOs can benefit from ACT Foundation. Okay, so Dr. Chine, would you like to go first, please?
Thank you. Yes, I think it's actually an excellent question and a very valid concern. What we have in our environment here in Nigeria is that, like the lady, Mrs. Ubong, I believe, said, patients are often being treated for their cancers by people who have not gone through specialist training in treating cancer. So, like you said, GPs, even some surgeons, for example, would do that. And I think it's because for a number of reasons. So first and foremost, the question is how many people get exposed to oncology training or oncology rotations when they're going through medical school in Nigeria. I think they're very few, and my colleague from NSI can probably help me with this, but I don't think oncology is something that is taught in a lot of the medical schools, and therefore people don't often realize the intricacies and the nuances of giving cancer treatment as opposed to just normal medication. So that's the first thing. The second thing is that there's a shortage of oncologists. Like in the whole of Nigeria, I believe we have between 80 to 90 oncologists in the whole country. So that makes it very difficult for those oncologists to cover the entire spectrum of patients that we would have in our population. But third of all, we don't have a robust accountability system. So a system whereby if someone does give chemotherapy that it shouldn't be giving chemotherapy, or if someone gives chemotherapy and does it incorrectly, how is that addressed? We don't have set systems where that is looked into, or set organizations where that is done. But and also we don't have the culture of it. So for one consultant, one doctor to flag up the error or the mistakes of another doctor is not something that is done very often here. And even as that's done, it needs to be done very carefully. So in the UK, for example, you do have these sort of meetings and assessments and feedback mechanisms in place, but they're always put in place so that it's not a situation where you're trying to strike the doctor, or they lose their license, or they get sacked unless they do something extremely, extremely dangerous. Most of the time, it's a situation where you can review what went wrong here, and how can we ensure that doesn't happen again without pointing fingers at particular consultants or turning it into a hunt to try and get rid of someone's license or anything that's vindictive. So we don't have those things in place yet, but I think more and more as patients and their relatives and their families become aware of what their rights are, we are getting into more and more of a culture where patients and families do question the treatment that their loved ones have had, and sometimes even go down the legal route of trying to get some sort of for ensuring that if something was done wrong, then the repercussions of that are felt. So I think what we need to do as healthcare professionals, I agree with the lady who raised the question, is ensure that we as the body of doctors start coming together to ensure that there is some accountability amongst us. And that means that the patients and their families don't feel that they have to take this on themselves. We don't have that in place yet. And I think it is something that we do need to start doing as a healthcare community and be more brave about doing it, as opposed to just turning our heads to the other side when we know that people are doing things that are not correct. Right now, what we do at Lakeshore is if we see a patient that's been managed in a particular way, we're quite keen on picking up the phone and just talking to the consultant or the other doctor who did something inappropriate and saying, we've seen this your patient, this is what we think is not correct. And, for future reference, we would recommend that you do it another way. So that's what we do at Lakeshore. I hope that helps answer the question. Thank you.
All right, thank you very much, Dr. Chineye, for that. So in addition to Dr. Chineye's comment, at Lakeshore Cancer Center, we have an e-learning platform that runs courses, health courses, that general practitioners can benefit from. So they do not interrupt, cancer care as a whole. So I have put the link in the bio, in the chat box, which you can share with health practitioners to benefit from and leverage from. So Mr. Ugochukwu, the last question for you regarding to how NGOs can benefit from ACT Foundation, please.
Okay, thank you very much for the question. We have a grant cycle that runs every year. The one for 2024 just ended. I mean, the grants are being reviewed now. There's also a second opportunity for nonprofits to get grants. That's like early next year. But then aside from that, we have general sessions that we run for NGOs. We call Sector Insights. We've also developed a set of books to help nonprofits to be able to either set up, develop policies, implement properly, and all that. Now, because you can't really help everybody at the same time, we do dive deeper with people who have become our grantees. They have more, we have more intense engagements with them. So for instance, something we call professional volunteer programs, but which is just open to those who have been our grantees in the past, of which today we have about 90 of them or so. So we have these are professionals who volunteer their time and help our different grantees out of the different issues they have at different times, right? So, but if you want to engage ACT Foundation, we're always open to listen, and then we can always point you in the best direction. You just send us an email. I think it's info@ACT Trust Foundation, and then we will definitely respond. Then just before I go, I just wanted to mention, I had Dr. Chineye talking about a structure. I think one of the things we should try to do for ourselves, I like what Lakeshore is doing as well, because I do know that in the West, they do have a particular document. I think right now they call it DSM-5. That's even just for diagnosing various mental health situations, right? I don't know if there's something like that around here that could also help, because what that does is that it even allows nurses to be able to diagnose someone properly. So all the diagnostic points are in this same document. So before you can say, oh, it looks like this person has XYZ, the person would have met certain criteria of things that are stated there. Okay, so I think that, I don't know how it is in the medical space today, but that is something that we will be maybe willing in some way to support, making it available to as many people as possible within that space, so that there is an opportunity for because diagnosis, like a doctor from last week said, is a very critical point, right? So I don't know how that is. I don't know how what the advocacy is. I don't know what the medical bodies are doing about it. But it will be good that people actually know that there is a guide to what they are being diagnosed of. And even as private citizens, we can actually look at certain things so that we can know if someone is giving us the proper guidelines. So which means you don't just need an oncologist to diagnose you. Anybody, even a nurse, can look at you and say, oh, these are signs of this. And they'll be like, okay, we are taking this person to an oncologist to take care of. Thank you very much.
Thank you very much. The last suggestion you gave is very vital, like the treatment guideline or diagnosis guideline. I think that would go a long way to reducing the friction between GPs and oncologists. At least they know what to do at the first point of contact before they are being referred to oncologists for care and for treatment. So unfortunately, we can't take more questions and comments for now, because we have exhausted our time limit for today. But I believe that this session was very impactful, because for me, I have learned a lot and I have carried a lot of wisdom from this session. Never to worry, the comments and questions have been noted down, and you can follow us on all our social media platforms, and you would receive a feedback to all the questions and your comments during the course of this week and next week. So thank you once again very much for joining us today for our webinar, and we hope that we would have more of this within the cancer space. Collaboration is very important for us, because we cannot do all of it on our own. We can only work together to achieve more. So thank you very much once again for joining us. And again, you can always register for our course at Learn with Lakeshore to have access to, cancer screening and referral as a whole, like the knowledge on it. So thank you once again, and do have a wonderful day. Bye-bye.
Thank you. Bye-bye.
Bye.
Thank you, everyone. Thank you.
Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thank you.